Hi, I am Mr. Neurologist and today I am going to discuss spinocerebellar ataxias. Spinocerebellar ataxias are a group of clinically and symptomatically heterogeneous group of disorders that are characterized by chronic progressive cerebellar ataxia, family history of cerebellar ataxia usually. And the most important spinocerebellar ataxias are spinocerebellar ataxia 7 and 10. Spinocerebellar ataxia type 7 has macular degeneration and type 10 has dementia. Genetic testing is available only for a subset of spinocerebellar ataxias. Now, there is a general introduction. Spinocerebellar ataxias are genetically and clinically heterogeneous diseases classified genetically according to a specific mutation or map locus and according to their clinical features. There are some spinocerebellar ataxias have mutations in calcium channel voltage dependent PQ type, alpha 1A subunit that may lead to spinocerebellar ataxia type 6 and episodic ataxia type 2 and familial hemiplegic migraine, which means that some spinocerebellar ataxia mutations may lead to other features and syndromes and diseases as well, in addition to spinocerebellar ataxia. Prevalence of spinocerebellar ataxia is 0.9 to 1.3 cases per 1 lakh. Spinocerebellar ataxia type 2 is most common. Spinocerebellar ataxia type 3 is most common, it is 21%. Then it is spinocerebellar ataxia type 2, it is 15%. Then it is 5 it is 15%. And 7, it is 5%. And it is spinocerebellar ataxia type 8, it is 3%. Now there is pathogenesis. Spinocerebellar ataxias are caused by expansion of CAG repeat expansion within coding region of their respective or involved gene. This repeat expansion is translated into an abnormal polyglutamine tract in corresponding protein, which is abnormal protein, and it is aggregated and accumulates in form of abnormal aggregates in nucleus, and that leads to nuclear degeneration and cell death. Now, prevention of spinocerebellar ataxia genetic testing is available. It can be offered to affected families, but there is no known intervention to delay symptom onset or to slow disease progression. Now, there are some clinical features. Spinocerebellar ataxias are progressive cerebellar syndrome with gait and appendicular ataxia, dysarthria, oculomotor disturbance, dysphagia, spasticity, breast tendon reflexes with extensor plantar responses, non-cerebellar oculomotor features, and signs of brainstem disease such as facial atrophy and fasciculations. And the repeat expansion of spinocerebellar ataxia is inversely correlated with repeat expansion, which means that if expansion is broad and it involves more CAG repeats, then disease is more severe and its onset is early. And with successive generations, disease occurs early and it is more severe, and the phenomena is called anticipation. And the phenomena of anticipation occurs with all diseases which involve trinucleotide repeat expansion. Now I will like to discuss some important spinocerebellar ataxias. First is spinocerebellar ataxia type 3, which is called Mikado-Joseph disease. In addition to symptoms and signs of spinocerebellar ataxia type 3 or Mikado-Joseph has gaze-evoking nystagmus, peripheral neuropathy, Parkinson-like features, dystonia of thalmopreces, fasciculations of face and tongue, and amyotrophy. In summary, spinocerebellar ataxia type 3 has Parkinsonian and oculomotor features. Now there is spinocerebellar ataxia type 7. In addition to specific signs of spinocerebellar ataxia, it has progressive pigmentary retinopathy, macular degeneration with visual loss, hearing loss, childhood developmental delay, dystonia, cardiac failure, microcephaly, hemangiomas, and hepatomegaly. And its DD includes Concierge syndrome and chronic progressive external ophthalmoplegia. And now there is another variant of spinocerebellar ataxia. It is called DRPLA. DRPLA can be divided into the disease before onset of 20 years and before the onset after 20 years. If DRPLA occurs before the age of 20 years, it is associated with epilepsy and mental retardation. And if it occurs after 20 years, it is associated with mental retardation and extra pyramidal features like Parkinson dystonia. Now, how will we investigate spinocerebellar ataxia? On MRI, there are no features specific. We will go for MRI brain and cervical spine, but MRI spine may show upper cervical cord atrophy, and MRI brain may show cerebellar or olivopontocerebellar atrophy, cerebral cortical atrophy, and white matter abnormalities. And other investigations, including genetic testing. Genetic testing can be done if a sporadic case has features very similar to one of inherited ataxias. Now, treatment. There is no treatment to prevent neuronal cell death in autosomal dominant cerebellar ataxias like spinocerebellar ataxia. Riluzole can be offered. Parkinsonian features respond to levodopa or dopaminergic medications. Seizures need anti-epileptic medications. Myoclonus requires benzodiazepines, valproate and levetiracetam. Spasticity is treated with baclofen, benzodiazepines, and Botox. Intrathecal baclofen, selective dorsal rhizotomy, tizanidine and dantrolene. Baclofen can be given 20 mg 4 times daily, and other alternatives already discussed. Prognosis of spinocerebellar ataxias. Time from symptom onset to death in spinocerebellar ataxia is 1 to 3 decades. The progression is slow in spinocerebellar ataxia 5, 13 and 21, and spinocerebellar ataxia type 8 and 11 have normal lifespan.